From the beginning of the HIV therapy, the drug-drug interaction has been a real problem in the clinical practice, especially after the use of options with booster like ritonavir and also cobicistat. Also from the beginning of the antiretroviral therapy, the University of Liverpool, especially with David Buck and Saye Khoo, has been working hard in an excellent work doing a website which is one of the most important websites in drug-drug interaction for all the antiretroviral therapy and all the other options of treatment for our patients. Now we have an additional problem that fortunately our patients are getting older, and the use of polypharmacy is a very, very common situation. I would like to thank to Saye Khoo for this opportunity of this talk about the challenges of antiretroviral therapy in the era of polypharmacy. Thank you so much.
Thank you. Thank you very much, Josep. And I'm sorry I don't speak Spanish, but it's a great honor to come here. Some of our most important collaborators are from Spain, and you all know who you are. And it's a great privilege to come and speak in your beautiful country. So here are my declarations. And I'm only going to talk about 3 things today. So I'm going to talk about aging, and from a clinical perspective, what is it really, is there really an aging effect on PK or PD or chronological or biological aging? A little bit about multiple morbidity, something that we all see a lot of now, and a case history just to illustrate some of the problems, and then a little bit about DDIs in the era of unboosted integrase inhibitors, so essentially raltegravir, dolutegravir, and bictegravir. So, because it's early in the morning, I'm going to start with the conclusions, and then I can show you the data later. So the quick question is PK meaningfully different? Now, I've put this word in because if you do a PubMed search, you will find plenty of studies showing some differences. So when I say meaningfully, I mean, is it clinically significant or is it clinically actionable? So in other words, there's so much variability. Is the difference in PK just lost in the noise of variability, or is it greater than the variability that you normally see with a drug, okay? So the first thing is you have to disentangle the effects of chronological age when we say it's aging against EGFR. So we know that after 50, your EGFR goes down maybe 1% per year. But there are plenty of old people with totally normal EGFR. Is their PK different? Okay? So, and the problem with a lot of these studies is that they don't dissect out the independent effect of renal dysfunction from aging. Yeah, and so you can see that the drugs that are renally excreted, tenofovir, FTC, 3TC, will behave differently with renal impairment and aging. And here's some data from the UK POPPY cohort. So this is a cohort of about 1,000 patients, half of whom are HIV positive and over 50 years of age on antiretroviral therapy. And then there are HIV negative controls and younger HIV patients. And if you look at the POPPY cohort, by quintiles of drug exposure, so this is the PK, the AUC. If you look by quintiles, you can see that there's a strong association with a drop in EGFR, or this is the beta coefficient, so the correlation, the strength of correlation between EGFR and drug levels. So you can see that that falls for the renally excreted drugs, tenofovir, FTC, 3TC, but not for abacavir, okay? So aging per se doesn't seem to be an independent effect once you've corrected for EGFR. And if you look at the other drugs which are non-renally excreted, there's either good evidence that they're unaffected by age, or else no evidence that they're meaningfully affected by age. Okay, so I'm not sure aging per se will change the PK of the non-renally excreted drugs over and above EGFR and body weight. So some of these drugs have a body weight effect, and of course, with aging and sarcopenia, you might get that. What about effects on compartments? So you're talking CNS and genital tract here. Again, numbers very small. Not a lot of good data, okay? A lot of the abstracts, the charter cohort presented some data about possibly higher levels of efavirenz and tenofovir in over 60 years old. This was a abstract presented in 2012 at CROI and never written up. I couldn't find it written up anywhere. So I think that the evidence is not strong. What about the evidence of menopause? I'll show you some data later on, but there's a lot of talk about estrogen and sex hormone receptive, estrogen receptive elements in promoter regions and helping to transcribe P450s. When you look at the studies, they are really small. They're all less than 20, and there's possibly some difference in raltegravir, but not a lot, okay? Cellular senescence, I'll show you some data on. Nobody knows what that means, but the strongest evidence possibly is around cellular senescence markers and tenofovir diphosphate and FTC triphosphate. There are important considerations with injectables. I'm not going to show you those data today, but Jose mentioned them. And the biggest drivers of exposure to rilpivirine and cabotegravir are body weight and gender. So if you have a larger body weight, your exposures tend to be lower. Unclear whether that's a volume of distribution thing only or whether it's a depth of injection, because the inter-individual, so within the same person, from injection to injection, the PK variability is large. It's as large as oral dosing. Okay, you'd have thought it wouldn't, but it is. And it seems to be variability in injection technique. So different people give different needles, which go in at different depths. And that may, so the combination of gender and body mass index is going to be quite significant for a lot of the injectables. I'm not going to talk about adherence. So I've shown you the POPI data, the postmenopausal data. I think overall the literature is inconclusive. There's lots of small studies looking at biopsies of the genital tract, looking at transporter expression, and I say these studies are very small, okay? If you look at other disease areas, clearance doesn't seem to fluctuate with either postmenopausal state or menstrual cycle. Okay, there's of course the issue about HIV acquisition and progesterones. I'm not going to talk about that today. I'm not an expert on it. Okay, and of course there are certain considerations in menopause, for example, bone loss, cardiovascular risk, that play onto that. But those tend to be pharmacodynamic rather than pharmacokinetic. I mentioned this study, which is a study by Julie Dumond and colleagues, where they looked at PBMCs and they looked at senescence markers. They looked at this marker, P1684A, reasonable numbers, and they looked at evidence for FTC, intracellular tenofovir diphosphate, FTC triphosphate formation, and there seemed to be an association with reduced active metabolite and increased cellular senescence. What does that mean? We don't know, because there is an excess of these, and it seems to be, there's no evidence of pharmacodynamic effects in this study, or generally in the old age population, which if anything responds better rather than worse in younger people. Then there is this interesting question, well, what does HIV drugs do to biological aging processes? So, you know, HIV itself associated with oxidative stress, these issues about telomere shortening with cellular senescence. So telomere shortening is prevented by an enzyme called telomerase, and that's got a reverse transcriptase element to it, the TERT subunit, which is telomerase reverse transcriptase. And in vitro, I won't show you the data, but in vitro, many or most of the nucleosides seem to be inhibiting TERT activity. So does that mean that actually a lot of nucleosides will make your cells age more? The real study comes from RCT data, and actually NEAT 001 did look at that. So there was a reasonable sub-study in size looking at telomere length. They looked at several markers of telomerase activity. Telomere length is just one example. I've shown you that. And you can see that rather than decreasing, it increases in the nucleoside arm, whereas it doesn't in the NRTI sparing arm. So actually, if anything, it seems to get better. It certainly doesn't seem to get worse with tenofovir and FTC. There are lots of there's a lot of interest in mitochondria as an aging. So your mitochondria deplete as you age. There are gender differences between males and females, and mitochondrial toxicity is thought to be responsible for a lot of idiosyncratic drug toxicities now as a mechanism. So what about mitochondrial function and mitochondrial DNA mutations which are introduced? Mitochondria DNA, there are no intronic sequences. There's a poor repair mechanism, so they're much more susceptible to drug-induced damage. And there are a few studies in this area. I've taken one from the Newcastle group, Brendan Payne et al. And there certainly seems to be, if you look at the older NRTIs, there seems to be much more mitochondrial damage. But there is an inherent confounder in this data because of amount of exposure and exposure to older drugs, the D drugs, which are much more mitochondrial toxic. So there's more exposure overall, and there's exposure to more toxic drugs. But there seems to be some effect with the older NRTIs of affecting complex 1 and 4 fibers. So I've basically painted a negative picture. I've said that actually PK isn't that different. Once you look at renal function, you adjust for that. Once you adjust for muscle mass and body mass index, then actually maybe older people may have slightly higher peaks, but the PK isn't very different. But if you go and look at the literature, people find you all sorts of reasons why the PK should be different in older people. It actually is probably only slightly different. What is really different is PD, okay? And we always ignore PD in drug interactions. We always talk about PK. The evidence for PD in older people is much stronger. So this will be familiar to you, those of you who practice this anticholinergic burden, and there's a scoring system now for it. But we know that multimorbidities cluster, and we know that there is a cluster that's associated with chronic pain, anxiety, depression, sleep disorders, and so if you take a man who's elderly on prostate treatment, there's anticholinergic there. If he's got a bit of depression and SSRIs, there's some anticholinergic activity. If he's got chronic pain and joint osteoarthritis, then there's some anticholinergics there. If he needs sleeping tablets, there's some anticholinergic, and these things all add up to an anticholinergic load. And then one day he falls, and the doctor who sees him sees an old person who falls and doesn't think about drug interactions. So one of the things we say to our trainees is, it's okay for people to get old, it is not okay for them to fall, okay? But clearly you need to recognize drug interactions before they come in with that broken hip. And so there's a big awareness training issue that needs to be done. Here's another example of pharmacodynamics with age. So this is amlodipine. This is change in blood pressure by plasma exposure of amlodipine. And you can see that at the same exposure of drug, younger people drop their blood pressure more than older people. So here's a situation where you're starting to have to balance anticholinergic load, hypotensive magnitude of hypotensive effect. You're looking at all these things in a young person versus an old person. Okay, polypharmacy and multimorbidity is associated with hospitalizations and death. It's probably no different or very little different whether you're HIV or not, but if you've got multimorbidity and polypharmacy, you're more likely to die, and this was data from the VA cohort. Data from Giovanni Goraldi's cohort also shows that, interestingly, if you have multimorbidity, if you have polypharmacy, and if you have no polypharmacy and you're frail or not frail, you do very well. If you've got polypharmacy and you're not frail, you do okay. If you've got polypharmacy and you are frail, your mortality is significantly higher, okay? So those are the people you need to really worry about. Not all drug interactions will lead to harm. So already you're seeing who gets harmed. And old people, people with multimorbidity, more likely to get harmed from the same drug interaction. I hope that you are aware of the drug interactions. We've done this as a response to the treatment, and you'll all be aware of the four categories. So green is no interactions. Yellow is no real interactions. Our lawyers tell us we can't call it green. So this is, everyone's clear, you don't need to do anything here. The red clearly there is a big problem, and it doesn't mean absolutely you cannot give the drugs for some of the interactions. So lopinavir, rifampicin, for example, is a red, but actually quetiapine, rifampicin is a red, but there are ways of getting around this. So for some of them, it's not absolute, but it's usually contraindicated, okay? The problem is the AMBERs. So AMBER does not mean you cannot give it, okay? AMBER does not mean that. A lot of people think that. It does not mean that. You've got 100 people with AMBERs, okay, and you've now got to take a view, what is the benefit for that person and what's that risk for that person? And this is where the multimorbidity, cholinergic stuff comes in, okay? So for some people, it will be green, for some people it will be red, and for some people you still don't know. So here's a case in point. So this is a patient that ended up under my care, so 59-year-old male, positive for a long time, start and stop, developed K103N, and potentially a suspected M184V. And of course the worry with that is you know, in those people you kind of think, until a few years ago you said that, well, we have to, you have to give a PI, okay? So if you've got any NRTI or NNRTI mutations, generally we say, okay, you've got to give a PI. Whether that's true nowadays with bictegravir, dolutegravir is maybe a question that we could discuss. So he's suppressed on Truvada and boosted darunavir. An HIV physician is very happy, despite the fact that his EGFR is gently drifting downwards. And so you've got this problem with his EGFR, his kidney function going down. He presents with multiple strokes, he's getting old, bit of cognitive impairment, AF, so someone's giving him dabigatran. He's got a bit of diabetes and poorly controlled HbA1c about 80, 90, hypertension, poorly controlled BP all over the place on amlodipine 10 milligrams, and hyperlipidemia, poorly controlled on pravastatin. The choice of pravastatin is driven by the boosted PI, the ceiling of amlodipine also driven by this, okay? We'll talk about that later on. So, HIV, happy, he's not going to die of HIV, he's got multiple morbidities, strokes, AF, diabetes, hypertension, hyperlipidemia. And the problems are many. This is a complex drug interaction. You've got tenofovir being boosted by lopinavir and his EGFR is gently going downwards. You've got the issue of dabigatran and ritonavir, and dabigatran being, and so that might have a magnitude of interaction that's not very big, but then you've got renal impairment that makes that bigger. So in someone with renal impairment, the drug interaction between dabigatran and ritonavir may not be qualitatively different, but it is quantitatively different, and that makes the difference between harm and no harm. And then you've got poor blood pressure and glucose control, so the kidney function is getting worse. And of course, he's just waiting. He's kind of one embolus away from that big stroke. And he's on pravastatin. And I don't know what your practice is here, but my understanding, I'm not a cardiologist, my understanding is that you've got statins that generally, all the statins will lower your cholesterol, but there are some statins that are anti-inflammatory and more potent as a result of that. And those statins are atorvastatin, rosuvastatin, pitavastatin, but not pravastatin. So pravastatin is not a high-potency anti-inflammatory statin. So he's on the wrong statin, basically. All right? And then you've got poor glucose control and hypoglycemia and the rest of it. So you've got this problem, poor adherence. Now he's got cognitive defects, he's got multiple DDIs, and his comorbidities are not managed. So we quickly talk about that. Cobicistat and ritonavir are not the same thing. So a lot of the cobicistat labeling is by guilt by association. But ritonavir is a partial, is a potent inhibitor, but also a partial inducer. So it's an inducer inhibitor. Cobicistat is a pure inhibitor of 3A4 and P-glycoprotein. So if you give darunavir, ritonavir and darunavir cobicistat, you can see darunavir levels are the same. That was a study that was done. Actually, darunavir troughs are slightly lower. But if you give darunavir with dolutegravir, then the dolutegravir levels, when you switch from ritonavir to cobicistat, your dolutegravir levels go up. Okay, so they're not the same thing. And we see that particularly in the interaction with dabigatran, which is a PGP substrate. So you've got this inducer inhibitor business with ritonavir, so it goes up, but that that upwards with, is slightly modulated with ritonavir, but whereas cobicistat is a pure inhibitor, it goes right up, it blocks PGP, and you've got dabigatran levels off the scale. So switching someone on dabigatran like him, if you want to switch from darunavir, ritonavir to Resolstra, you might get a very big risk of bleed. Okay? And on top of that, you've got the renal dysfunction that I mentioned, which is pushing dabigatran levels upwards. Some data, you've already know this with clopidogrel versus prasugrel. Clopidogrel and prasugrel are both pro-drugs. They're metabolized, they're converted by CYP3A4, not 3, by P450, so CYP3A4, and a bit of 2C. So there is some conversion, and that's blocked by both cobicistat and by ritonavir. And so the active metabolite reduction is less, but with clopidogrel, the antiplatelet function is lost. Okay, with blocking, whereas in prasugrel is retained. And prasugrel has slightly different metabolic pathways. It's also metabolized by carboxyesterase. There's a lot of redundancy. So prasugrel is a better choice than clopidogrel for people on boosted regimens. Okay, so you've got this situation. You can switch them from tenofovir to TAF. So you might, and if you've done that many years ago, you might have got a better result. It still doesn't get rid of, it doesn't get you around all these other things. We talked about cobicistat and ritonavir, and so then the question is, in the presence of potentially even an M184V, are you happy to use bictegravir and dolutegravir? What is the evidence that 3TC, FTC has residual activity in the presence of 184V with integrases? There's plenty of evidence with boosted PIs. There's some evidence, but the numbers are much less. So I've just pointed to the fact that actually the fear of drug interactions in this patient is what's going to kill him, okay? Because his comorbidities are going to kill him and they're not being managed well. And there's plenty of evidence from London that patients on statins and boosted PIs are not controlling their lipids. There's evidence from Italy that psychotropic drugs are underdosed when given with HIV, particularly with boosted PIs. How does this pan out in 2019 with the increased use of integrase inhibitors? Okay, so we're using a lot more integrase inhibitors now, and interestingly, not all people are using a lot more integrase inhibitors. So this data from the UK showing that actually older people are more likely to stay on efavirenz, and it's the young people getting Triamec. Okay, these data are from the PUPPY cohort. So I mentioned the PUPPY cohort earlier on, and the PUPPY cohort mapped the comorbidities in these HIV-positive patients, and there were 4 disease clusters. There was a STD cluster down here. There's a mental health cluster, which I talked about, the sleeping problem, depression, anxiety, chronic pain, panic attacks, and that's one cluster. There's a cardiovascular cluster, which is angina, ischemic heart disease, hypertension, and an overlapping cardiometabolic cluster, which has also got hypertension, diabetes, dyslipidemia. So the patient on amlodipine is likely to be taking metformin and a statin as well because of these clusters. So they're not evenly distributed cluster, and they cluster because of the same risk factors like smoking or the same genetic factors, okay? And importantly, the big drivers of these clusters consistently are number 1, aging, number 2, obesity. Okay, so obesity is driving these clusters as well. So if you look at boosted PIs, and efavirenz will be something here, you look at the 3 clusters here, the mental health, the cardiovascular, and the metabolic cluster, against the Liverpool database, so amber or red. You see that about 40 to 50% of all those drugs, all the sleeping, the anxiolytics, the antidepressants, SSRIs, 40 to 50% of those drugs will have a amber or red with older boosted PI regimens. Slightly less for efavirenz, but still high. Today's regimens, and these are all the single pills, are all very, very low. And it's not just integrases. Doravirine, rilpivirine, all low, okay? In fact, I would say that nowadays, if you had a new drug and it had a lot of DDI effects, probably in drug development, it would not survive. Okay, so, and there's no difference between 2 drugs and 3 drugs. So there may be reasons for 2 drugs and 3 drugs, but drug interaction is not one of them. Okay, there may be, you can see today's modern regimens, the relative risk of drug interactions is down. Okay, relative risk of drug interactions is down. The absolute risk of drug interactions is not really changed, okay? And the reason is that though the drugs are cleaner, people getting older and collecting more morbidities. And so I'll orientate you. So this is a survey I did. So these small dots are about sample size 1 to 300. This is about 1,000. This is about 2,000, okay? And this big study here is about 23,000. That study is 9,000. That study is 4,000, okay? So this is the size. The color, the orange is Europe, the blue is Africa, and the red is America. And you can see that in the last 10 years, the last 15 years, drug interactions have hovered around this level. They're slightly different in Africa compared to Europe, so there's a bit of antimalarials and TB drugs. But if you look in 2019, there's a big spread, and that reflects two things: the downward pressure because people are using more integrases, but the upward pressure because people are getting older. And so the amount of drug interactions that you see in your cohort seems to be, in my mind, related to how much integrases are used. So if you look at the UK or Barcelona, where integrase use is less than, say, France or Madrid, you'll find that there are differences in terms of drug interactions. But the culprits are all the same. It's steroids, it's statins, it's quetiapine, it's PPIs, okay? And amlodipine. Those are the top, and they're the same if you look everywhere, pretty much. NOACs, dabigatran, apixaban coming up fast. Right, and you're all familiar with the podium study, which Juan led, and again that showed that around 2% of people had a red flag, and in the Swiss cohort, around 2% as well, very consistent, and a large proportion of those, the biggest proportion of those are steroids. So there are plenty of people walking around with steroids and a boosted PI around the world, in Spain, in London, in Geneva. And it's not because HIV physicians don't know how to manage steroids. In 2019, we do. It's just because we don't know that somebody else is giving them steroids. And a lot of these are injections. I recently found out that people with multiple joint or multiple nerve root conditions requiring injection get the same dose of injections multiple times. So if you've got 2 nerve roots, you get double the dose of steroids, okay? And that's quite frightening when you're on ritonavir. Right, I'm going to finish very soon now. So we talked, Jose talked about the BMI, the obesity, and I told you that obesity was a big driver of the multimorbidity cluster. So what does dolutegravir and bictegravir, what does that weight gain mean? Okay, what's it going to do to the multimorbidity cluster? We don't know. All right. There's emerging data on integrase inhibitors in diabetes, some preliminary data from Uganda with dolutegravir, some data from the NA Accord, data here showing that raltegravir and PIs, there was a much higher increase in incident diabetes. Are we over-egging this? Because the vast majority of people on dolutegravir in my practice don't put on weight and don't get diabetic. So we need to understand this in the context of the undoubted advantages of rolling out integrases. So I'm going to finish here. I'm going to say that you already know the potential for drug interactions. I talked about the relative risk and the absolute risk. I think that this is still a problem. I think that the unrecognized risk is the biggest problem. We need a full medication reconciliation. And in the UK, they say at least once a year, you must document in the notes that you've done a full medication reconciliation. That is to say, talk to patients about oral contraceptives, recreational drug use, and non-oral steroids, okay? So chase those things down, traditional medicines, recreational drug use. And I will stop there. And acknowledge the group of the work of the HIV group, and Katia Marzolini, Fiona Mara, and of course David Back, my colleague. Thank you very much.
Preguntas? Questions? ¿Hay alguna pregunta? Let me ask you, you showed that when the kidney when the kidney function is decreasing, there are some concerns about some drugs like 3TC and FTC, but 3TC is an excellent drug. In more than 25 years, it's impossible to find any drug adverse event. And so I think there is some concerns about this topic, because do you really believe that we must modify the dose of 3TC or FTC in these cases?
It's a really good question. So I get asked this, and I also get asked this about in the context of hepatitis B as well. So my view with 3TC is that actually it's such a safe drug that you could overdose it several times over and not really get very sick. So I'm very careful that this is off-label now. So you remember the NUCB study, the NUCA and the NUCB study, this is going back to way really old stuff. That was 600 milligrams a day of 3TC. That was a really high dose. They were all happy. So for the borderline, so 3TC obviously has clear guidelines about dosing with renal, but for the borderline patients, I tend to not drop the dose for that reason, exactly.
Thank you. Dr. Miro.
Excellent presentation. My question was similar to Jose Mayola's question. So in addition to 3TC, also TAF, because TAF and FTC and 3TC are included in almost all single tablet regimens, so our population is aging, renal function is deteriorating, so and in order to avoid more polypharmacy, it's important that not broken the STRs. No? In patients with glomerular filtration rate below 50 or even below 30. So we can maintain the full doses of TAF, FTC, and lamivudine. John Aaron published a year ago in patients in dialysis that they maintain full doses without any important side effect. And this is important because the number of people that will have this problem will increase in the future.
You're
so
right.
TAF, FTC, and lamivudine.
Yeah, so TAF data is, there's less TAF data than 3TC for the high doses, but of course America doesn't have a 10 milligram of TAF, so they give all their boosted PIs with 25 of TAF and they seem quite happy, and the kidneys are not falling to pieces, so I assume that that's a natural experiment that's already been done on a wide scale.
Okay.
Thank
you. My question, sorry. My question is about long-acting therapies. Given the long half-life of long-acting therapy, are all the HIV patients good candidates for this kind of therapy with the possibility of drug interaction?
So all the what patients?
All the HIV patients and long-acting therapy.
Oh, all the HIV.
Yeah.
Yeah, I don't think it'll suit everyone. I know people talk about tablet fatigue. I think one day people will be talking about injection fatigue, because I don't think it's for everybody. You know, you think that long-acting drug therapies, I'm going to talk off-label now. So people will think with injections there is better adherence, which is true, but the blips, as I understand it, are not very different. You might think that there's more consistent PK. That is not true. There's just as much inter-individual variability. You might think that there are less drug interactions because cabotegravir and rilpivirine are relatively clean, and that is true. But injection is not going to give you less drug interactions. It will reduce the gut-based interactions, so you can take injections with PPIs, antacids, and multivitamins. But there are new interactions that you may have to think about. So what about your patient with dabigatran? Are you really going to inject them twice, two injections every month when they're anticoagulated? So what about, you know, we have this issue with moderate inhibitors. So rifabutin, you can double up the dose of rilpivirine, for example, but you can't do that with an injection. So the DDI are not going to be less with injections. They're going to be different.
Pues si no hay más preguntas, personalmente agradecer a Gesida su amabilidad en contar conmigo para moderar esta sesión Agradecer a los ponentes y creo que en nombre de la doctora Merino y yo personalmente también agradecer a José Ramón y a Saye las magníficas presentaciones y a todos vosotros por haber venido. Muchas gracias.